Welcome, everyone. I'd like to welcome you to the launch of the report, Crisis Communication and Vaccine Uptake in Fragile African Settings. I'd like to thank the partners for today's event, the Center for Pandemic Research at the Institute for Research and Policy, ICERP, at Columbia University, Frontline Nurses, Center for the Study of Social Difference, the School of Nursing, the Program in Vaccine Education at the Vagelos College of Physicians and Surgeons, the Columbia Global Centers, the Earth Institute and Columbia Climate School, and the Academy of Political Science. My name is Bob Shapiro. I'm president of the Academy of Political Science, and I'm a member of the executive committee of the Center for Pandemic Research at ICERP and professor of political science and international and public affairs at Columbia. I'd like to introduce our speakers today. I just want to give their brief bios. Wilmot James, who will be speaker and co-moderator with me for today's session. He's a senior research scholar at ICERP and associate director of the program in vaccine education at the Vagelos College of Physicians and Surgeons, Columbia University. Dr. Tom Frieden is a physician trained in internal medicine, infectious diseases, public health, and epidemiology. He's the former director of the U.S. Centers for Disease Control and Prevention and former commissioner of the New York City Health Department. Dr. Frieden is currently president and CEO of Resolved to Save Lives, an initiative of the Global Health Organization, Vital Strategies. Dr. Chinwe Lucia Ochu is a medical doctor with over 24 years of experience as a clinician. Dr. Ochu currently works with the Nigerian Center for Disease Control as the acting director, prevention programs and knowledge management, and as the head of research. And last and not least, Youssef Cherif is the director of Columbia Global Centers, Tunis. He is a political analyst who specializes in North African affairs. He's a member of Carnegie's Civic Research Network and contributes to a number of think tanks. What I'd like to say at the outset before introducing our first speaker is that we're going to be using the question and answer function. So you can begin typing in questions that you have for speakers at any time, and we'll come back to the questions at the end of the session. And without further ado, I want to introduce Dr. Tom Friedman, president of Resolve, who's the author of the report's preface. Dr. Frieden.
Thank you very much, Bob, and thanks to Dr. James and the team there in the Academy for bringing us together. The COVID pandemic has really amplified the crucially important role of effective communication in a public health emergency. Effective communication has to be driven by data and a combination of good data from different fields, public health, social science, and others, as well as sensitive communication practices. The fundamental concept is to be first, be right, be credible, be empathetic, and give people practical, proven things to do. We have to reach every corner of every community, leaving no one behind, and especially focusing on those areas that may be suspicious of the government or of mainstream media. It's even more essential when the behavior of individuals and communities can have a direct impact on the health of others. Taking time to listen is a crucial part of effective communication. Communication to be effective has to be two-way. We need to not just hear the sounds, we need to listen to the thoughts, the emotions, and the perspectives. We need to acknowledge what people are saying and respond with empathy, not just canned talking points. Communication is most effective when we carry messages that are practical and concrete. What we have long known is that if you don't give people useful things to do, they may do things that are less than useful, particularly if they're quite concerned about a situation. Consistent messaging is important, not just from the government, but amplified by community influencers, faith leaders, other trusted voices. It's essential for messaging to be received and acted on, and that is essential in turn for translating science into action. We need to reduce the complexity to increase the accessibility of information without in any way dumbing it down, just being good communicators. Trust is essential to effective communication. Focusing on scientific evidence with transparency and clarity to build that trust. Trust is the one thing that you cannot surge in during an emergency. You have to build it over time. Societal and public health leaders need to tell people what we know, how we know it, when we know it. We also need to be open about what we don't know and what we're doing to try to find it out. This means communicating that there are still many unknowns, that evidence may change as we learn more, and what we recommend may change as we learn more. That's the way to combat misinformation, which, as we know, can spread even more rapidly than the virus itself. We see inaccurate, misleading information about COVID, the virus, the treatments, the vaccines proliferating, often via social media. We need to counter that misinformation by presenting clear facts, amplifying messages, and also telling stories. Information spreads when it's told in a story. Being trusted and credible, listening, acknowledging, presenting facts, being truthful and complete with impactful stories and consistency. All of this is crucially important, but very challenging in today's media and social media environment. But it's the best weapon we have against false and potentially dangerous misinformation. At Resolve to Save Lives, we've worked with a coalition of groups to create the Partnership for Evidence-Based Response to COVID, which began over a year ago to bring together epidemiologic and other information about the trajectory of the outbreak and various data sources from population surveys in order to inform policy and communications. Surveys have been done in 20 African Union member states. They've helped understand the acceptability, impact, and effectiveness of public health and social measures to control COVID. One overarching response is that many people feel that they lack the information they want to make informed decisions. Effective risk communication systems can fill these gaps and improve people's knowledge and give them the confidence they need to take appropriate action. The Crisis Communications Report from Colombia focuses on important information and perspectives on the African situation and context. The principles and lessons learned are really important, and they're applicable globally and not just in Africa. This includes that public health and social measures can be difficult to implement, even though they're critical for pandemic control, especially among the most vulnerable populations. The more disruptive measures are to day-to-day life, the more important it is to engage with communities. We need to work to engage people to implement effective solutions that balance a critical concept, that balance the epidemiologic control against the cultural, economic, and social context and risk. As we move to vaccination, engaging communities is even more important. The pandemic is far from over, and it won't be over until we get vaccines to the entire world. We have a two-track pandemic, some high-income countries putting the pandemic behind us, and the rest of the world still very much struggling with an uncontrolled pandemic. Low and middle-income countries, especially in Africa, are at high risk, with the third wave already underway in Africa and the Delta variant, a much more infectious variant, just beginning to get a toehold there. We will sadly need to continue the public health and social measures where the pandemic is still uncontrolled and vaccines remain in short supply. Vaccine reluctance is very real and has many causes. This can be addressed with targeted and effective communication. We need to increase vaccine acceptance and prepare for vaccine availability even before it's widely available, something very difficult to do. We can prime the pump to increase the demand for when vaccine supply increases. And this can be done in many different ways, including one-to-one outreach by close personal contacts, family, friends, and coworkers, doctors, and others. Refining and strengthening risk communication strategies now will reduce the time it takes to get through this next phase of the pandemic and also lay a stronger groundwork to address future health emergencies and help ensure that we can keep the world as safe and well prepared as possible. Vaccination is just one of many challenges we face in effectively responding to COVID, and we need to balance availability with the messaging. And this is enormously challenging, but enormously important. So thank you so much for doing this crucially important report. And I'll now turn it over to Professor James.
I just want to chime in briefly and thank Tom for getting us off to an excellent start. I want to turn the floor over now to Wilmot James, who will offer his reflections on the report. Wilmot.
Thank you very much, Tom, for your introductory comments and overview of where we are. So we are delighted to release the report today, titled Crisis Communications and Vaccine Uptake in Fragile African Settings. This report is based on a larger symposium we held in March, and we're extremely delighted to be able to make it available publicly. So the context in which we are releasing this report is as follows: that the WHO reported that of mid-June, that wealthy countries have delivered 60 vaccines per 100 people, whereas in low-income countries, it is 1 vaccine per 100. So just think about that number, 60 to 100, 1 to 100. African vaccination figures continue to lag. The Africa CDC reported that 2.37% of all African populations living in Africa's 54 countries and 2 disputed territories received 1 vaccine dose, and 9.76% received 2. Apart from the island of the Seychelles, only Morocco's vaccination rates are in fact in double digits, with 16% of its people fully vaccinated, followed by Equatorial Guinea, Tunisia, and Zimbabwe. In terms of sheer numbers, Egypt has delivered the most vaccinations. This topped 3.3 million, but this is in a country with a population of 100 million and where 2 doses are required. COVAX is a great idea. It's a remarkable innovation, but support for it from the countries of the North have been disappointing. Not enough supplies, clearly. The G7 countries announced that they would be donating 807 million doses to countries in need, primarily through COVAX, but no details as to process or timeline. Observers who counted on an ambitious vision were left disappointed. The former UK Prime Minister Gordon Brown called the summit an, quote, an unforgivable failure over the poor progress made in vaccine plans. So Dr. Tedros noted that making those vaccines available will be too late for many who are at risk today. This has 3 key consequences. First, the longer it takes, the more hesitant and suspicious populations become. Secondly, countries now have to rely on public health social measures much more than before, but we cannot go back, however, to economically damaging lockdowns. And third, opportunities, as we've seen, for new variants to emerge and create havoc in the epidemic environment is increased with low vaccination rates. The implication of that is it calls for smart, tailored interventions, and it calls for targeted risk communication in support of public health social measures. What we require is a campaign or a series of campaigns. And these would have the following components. We have to accelerate supply and delivery of vaccines, but there's some hard barriers here. Firstly. Secondly, we have to plug the information gap when it comes to vaccine safety. Third, on this front, Africa is better off when it comes to attitudes towards vaccines, given its recent history with vaccinations on the continent and an infectious disease burden. But there's regional variation, and what we have to do is plug that information gap. Resolve to Save Lives have conducted a number of surveys that are really instructive about why it is that individuals do not want to be vaccinated. And if I can just cite some figures for you. In the case of South Africa, the top 3 reasons is firstly that 27% of South Africans do not believe that a virus exists. 25% say that they are not being vaccinated because they do not know enough about it to make a decision. And third, 18% believe that they are confident that other treatments will be coming soon. That's the case in South Africa. Contrast this to Tunisia, that the biggest percentage, 30%, believe that they simply don't have enough information to make a decision. It's just an information gap. 20% believe that they're not at risk, and 15% say that they do not trust the health authorities. In the case of Tunisia, the military has more trust than the health authorities. The key finding here, takeaway here, is that the most important reason that people are refusing to take vaccines is that they simply don't know enough to make a decision. They don't have enough information. And therefore, risk communications is clearly important in providing that level of information. It's a massive opportunity. A second finding from the Resolve to Save Lives survey is that it identified who the 5 most trusted institutions are and individuals are in a given society. And I'll give you an example. In the case of Ethiopia, the most trusted source of information comes from the Department of Health. The second most important trusted source are from health centers or hospitals. The third would be religious institutions. The fourth would be the media. And the fifth would be your national public health institutes. I want to contrast that with Tunisia again. The most trusted source of information in Tunisia is the army or the military. The second would be community health workers. The third would be religious institutions. The fourth would be the police. And the last would be politicians. Okay, so it tells you a lot. So the important thing about this is that the implications for communicating risk in African settings with that level of evidence and information is that, first of all, countries must up their game. Secondly, a much smarter use must be made of trusted individuals or institutions that the Resolve to Save Lives surveys have identified as the most trusted individuals as risk communicators. Third, there's a need to now micro-target audiences rather than having a blunt national instrument. You have to micro-target the audience, and now we have much more information on who those audiences are. And thirdly, very important, we have to get the message right, requiring transparency, disclosure, and the truth. People simply need to know what's going on. To do this is a challenge in politically stable countries with organized governments. What about countries at war? There are 15 African countries presently engaged in some kind of war or another. What about post-conflict countries trying to rebuild, like Libya? What about countries experiencing high levels of internal strife? What about areas of the continent where governments have no presence at all, and where there are large refugee camps and no-go areas? What are the lessons about what works? In our report, Crisis Communications, we're releasing today, cover key fragile environments in Africa. There are many success stories in Africa. To know that Africa is a vast continent, and therefore any kind of solution that we would offer in terms of what works and what does not work cannot rely on a one-size-fits-all architecture. But here are some general statements about risk communication and in community engagement that you can glean from the report when you read it. The first is that when it comes to risk communication, it is absolutely important that there is consistent messaging. Nothing is worse than inconsistent and contradictory messaging. There also has to be consistent communications, community engagement in order to build trust. And as Tom Frieden pointed out, you can't invent trust today. It's something that's built over time. And it's built over time between citizens and the health institutions that serve them. And that cumulative relationship of trust is something that requires a longer view and long-term investment. Community engagement is also important, obviously, to help people and to help their families. It's not simply a blob. A community is a community of individuals, of families, of networks, and we need to know how that is put together. We need to know how that works. So, secondly, health promotion campaigns are critical for informing communities about how they must access their health services. There is more information today about the secondary knock-on effects when it comes to dealing with COVID for other aspects of a country's disease burden. And how risk communication works is if you have a simultaneous strategy for lowering the barriers that people face when they try to access health services. And there are many barriers, logistical barriers, geographical barriers, and social barriers, and economic barriers being a very, very key part. And third is to emphasize the importance of partnerships and collaborations with existing formal and informal social networks. This includes tangible support, in particular to women's groups who have been playing a leadership role in Africa and elsewhere, tangible support to community groups, and tangible support to civil society groups to play an outsized role in supporting frontline pandemic response in the developing world. So the priorities for us, in sum, upscale supply of vaccines, upscale delivery and immunizations, and run smart campaigns using smart messaging, emphasizing the continued and vital importance of non-pharmaceutical interventions without going into hard lockdowns, using the important and improved data sources that have become increasingly available. And with that, I'd like to hand back to Dr. Shapiro.
Thank you for that excellent and compelling discussion. I just want to remind the audience, please type in your questions in the Q&A box. And I just want to alert everyone that Dr. Frieden has to leave early for another engagement. And with no further ado, I'd like to introduce Dr. Ochu, who will talk about this from the context of Africa. Thank you.
Thank you very much. Yes, thank you very much, Robert. And thanks, Lord James, for laying that very good foundation. It's a great privilege to be able to share Nigeria's experience in the report that is being launched today. Nigeria, like other African countries, have had very poor access to vaccine, with less than 0.02% of the entire population having received 2 doses of the AstraZeneca vaccine. In other African countries, in the whole of Africa, we've been able to roll out just 32 million vaccines, with only 12 million having had 2 doses of vaccine. This is still less than 1% of the total number of vaccines that have been given out globally. So Nigeria and the rest of the African countries have had very poor coverage of COVID-19 vaccine. And complicating this is also the issue of vaccine hesitancy. And some of the factors, major factors that drive this hesitancy in our context have been pointed out before now, COVID fatigue, the fact that people are getting tired of hearing about COVID, and also the issue of infodemics, widespread false information about the virus and also about its vaccine. Africa has had a very different trajectory of the pandemic than was initially expected. So the fact that we've not recorded many cases of COVID-19, nor many cases of death, has led to people having very low perception of risk. But it's also good to know that this might not be the actual case, because the serosurveillance, the serosurvey that we had that covered 4 states in the country was able to identify a very high prevalence in one of the states that was not reporting as many cases, up to 24% of seroprevalence of COVID in that state. So a lot still needs to be done. And like Tom Frieden said, we need data to be able to know the extent of the virus, the pandemic in the country, and to also guide our vaccination efforts. Another problem has been distrust of government and government institutions, also as a result of infodemics, the false information that is moving around. With inadequate community engagement insecurity in some quarters, some parts of the country have issues and problem with insurgency, different levels of insecurity that has hindered access to those fragile communities. So this has informed our strategy as a country we have emphasized and prioritized innovative strategies to address COVID-19 vaccine hesitancy and to improve acceptance and coverage. And we've also discovered, and it is important to note, that these are strategies that must build public trust in our public health interventions. And for this to happen, the processes must be transparent, and there must be deep-rooted public health community partnerships that will foster community ownership and ensure sustainability of our public health interventions. We've tried to effectively manage infodemics in the country. In Nigeria, we identified and implemented a robust infodemic management system that is contained in our risk communication and community engagement strategy. And this management system is based on dynamic listening and rumor management. We try to detect, collate, investigate, analyze, and make decisions on the trending issues that we scope and get from the media. So there is this app that scopes regularly the existing social media channels and other traditional media channels to identify what are the trending news, what are the trending information out there, and to categorize them either as misinformation, disinformation, risky behaviors, and then to seek to develop craft risk communication messages to address those trends. So we strengthened community partnerships, identifying and engaging opinion leaders and trusted voices such as religious leaders and leaders of faith-based organizations, traditional leaders, and especially the healthcare workers. Like the survey and the report from Resolve to Save Life shows, healthcare workers are one of the key trusted voices that people tend to believe more than the other categories of workers. So we've leveraged these trusted voices in championing our risk communication messages and efforts. And it is very, very important for us to know that as a global community, we need to engage communities and to strengthen community structures and partnership to be able to drive acceptance of our public health interventions. In Nigeria, fortunately, we've had a very successful polio eradication campaign. So we leveraged existing structures using the community-based organizations and all the polio eradication structures in promoting vaccine acceptance and vaccine coverage for COVID-19. We've also identified the need to engage end users and target populations in the development and implementation of our public health interventions. This is the only way they can take ownership and be able to sustain these interventions. We've partnered with the military and other civilian task forces to seek to improve our access to fragile communities. There are some parts of the country that it will be difficult to penetrate, it will be difficult to access without partnering with the military. So the importance of collaboration with relevant stakeholders has been very, very highlighted in our response to COVID-19. So these are very important strategies that we have used and we keep using. In Nigeria, that community level participation in public health intervention, development, and implementation has been very key in the way we responded to this pandemic. So I am happy that we've been able to capture all this, even in the reports that is being launched today. And hopefully this will inform the global strategy on improving vaccine acceptance and coverage, not just in the high-income countries, but in both high and low-income countries. So thank you very much. I will hand over back to Robert to continue with the discussion.
Thank you. Thank you for that further enlightening discussion about what's been happening on the ground there. And now on to Youssef Cherif, Director of Columbia Global Centers, Tunis. Please.
Thank you very much. Hi, everyone. It's a pleasure to be with you and to see that the report is finally out. So my focus will be mainly on North Africa, and it will be a little bit different because I'll focus mostly on the political aspects that are related to COVID-19 and to the vaccines dissemination. So in March, we mentioned the issues related to vaccine distribution and vaccine communication. By then, one of them, I mentioned political instability and political struggles. So as I said, my topic today will be around that issue. And actually, I'll start by saying that since the pandemic began early last year, most governments, or all governments in the MENA region, issued statements about the danger of COVID-19 and about the issues related to COVID-19. So we've seen the governments in Tunisia or in Algeria or Morocco quickly taking decisions to face COVID-19. But when you look carefully, you will see that it was not their ultimate priority. And I often compare this to how these same governments reacted to issues of terrorism and extremism 10 or 20 or 30 years ago. By then, that became their ultimate priority. And we've seen these, by then all these states were quite authoritarian. We've seen these authoritarian states upgrading their authoritarianism in the name of fighting terrorism and extremism and so on. But with COVID, they saw that as an issue, but not as the most important or the most pressing issue. So I give you examples across the spectrum. Again, I'll be talking about North Africa and more exactly about the Maghreb. In Libya, the war that the country has been going through since 2011 continued actually until early 2021. Of course, now the situation is a bit better, but until just a few months ago, people were different armies were fighting, and the main focus of Libyan politicians and soldiers was on fighting each other more than fighting COVID-19. And today that the war has basically ended, or at least there is a stalemate, when we look at how Libyan politicians act, they're actually not always wearing masks and so on and so on. In Tunisia, there was a political crisis again since 2011, but the political crisis, if you look at when it really exacerbated, that was in summer 2020. So exactly a year ago, when the country left the first wave of COVID-19 rather unscathed. The government did quite well in managing the first wave, but then the different political parties started bickering, and the country today is in a big political turmoil that really exacerbated in summer 2020. In Algeria and Morocco, the authorities cracked down on opponents more and more massively in summer and fall 2020, rather than working together with civil society on vaccine distribution and communication, etc., etc. In Mauritania, there is an anti-corruption campaign that kept moving forward during all of 2020 and 2021. So just to say that, again, the priority of these governments was elsewhere, and the political tensions that I just mentioned, they did exhaust the energy of the leaderships of all 5 states of the Maghreb region. Their attention was away from COVID-19 and away from looking for getting vaccine jabs to their populations. And the result is what we see today: limited vaccination campaign by summer 2021, apart, and Professor James mentioned Morocco, apart from Morocco that is faring quite well in comparison to the other North African states. So here, we look at the numbers, and as I said, Morocco is doing quite well. In Morocco, we have more or less 20% of the population that got vaccinated. Most of them got 2 shots. Many more got 1 shot, but also had COVID in the past. So at least 20% of the population is rather protected. They got AstraZeneca, Sinovac, and Sputnik. And you notice that BioNTech is not very active in Morocco. And Morocco actually started the vaccination campaign quite early in late January. In Tunisia, however, the vaccination campaign only started in mid-March, so around less than 3 months ago. In Tunisia today, there are less than 4% of the population that are fully vaccinated. And in Tunisia, again, important to our discussion today, only 25% of the population registered to get, less than 25% of the population registered to get a vaccine because of the things that Professor James mentioned, not being aware about the vaccines, not trusting the government, etc., etc. In Algeria, and I think Algeria is the biggest issue today when it comes to COVID and vaccine in North Africa, because Algeria has a population of 44 million people, but less than 3% of its population is vaccinated, and at least to the latest account, they are only partly vaccinated, not fully vaccinated. So that's a time bomb for the upcoming years. And Algeria Algeria actually started early the vaccination campaign, but for different reasons, again, that was not the main priority, so they did not get enough vaccines on time. Libya actually was the last one to start the vaccination campaign in mid-April, once really the war calmed down. Less than 3% of the population is vaccinated, and again, partly vaccinated. And the issue with Libya is that there are very little information about what's happening there because of the dysfunctioning that the war brought to the country. So that's also a big problem, but the Libyan population is actually quite small. So we're talking about less than 6 million people, and therefore it is still manageable as a situation. Mauritania also vaccinated less than 1% of its population, and it started quite late. In March, actually, it started vaccinating its population. And therefore, we see that apart from Morocco, in a way, and again, Morocco, we're not talking about 50% of the population that is vaccinated. Apart from Morocco, the other North African countries are doing quite bad, and that's actually creating a lot of issues in the countries. In Tunisia, for instance, this summer was supposed to be the summer when tourism would restart, but because there are only a few people who are vaccinated, the summer season is dead, and that has a lot of repercussions on the economic issues, on the economic situation of the country. But I think perhaps more dangerous than the economy, it is actually deepening the mistrust between the populations and their authorities, and actually deepening the mistrust between the populations and the state in general. So you see more and more people in these North African countries who do not trust the state at all, and who feel that the fact that their states did not provide them with vaccines on time, I talked to a few people in Tunisia and Algeria who told me that for them, these are state crimes. They gave the states their health, and the states did not take care of their health. So again, this is deepening the mistrust between citizens and the governments, and that may lead to more and more social instability in the future. Thank you.
Okay, well, thank you very much. We've had very interesting discussions from all of the panelists. Wilmot, do you want to follow up with any questions for the panelists? Meantime, the audience should type their questions in the Q&A, and I have some questions as well. So Wilmot?
So thank you very much for that wonderful series of reviews. One of the questions that I'd like us to discuss as panelists has to do with how one combines public health social measures with a vaccine rollout. Because it's obvious that with a low vaccination rate, what that does, it creates opportunities for new variants. There is a new Delta variant that is really quite pathogenic in terms of transmissibility and its health consequences. And so when countries have low vaccination rates, which is across the board in Africa, even surprisingly in South Africa, then what that does, it creates massive risk in terms of the pandemic as it unfolds. So what is important is that it has to be accompanied by the strict interventions on the public health social measures side. And that's about masking, that's about social distancing, that's about those things we know that works. And so the question is, how is that going in the countries that we are talking about? In the case of Nigeria, we know Nigeria is politically complicated, 36 states that has to be brought together. Northern Nigeria is at risk, just given the security situation in other parts as well. So, so if I can ask Chinwe to respond to that, it'd be great.
Thank you again, James. I think very interesting question. Yes, I will say that it has not been easy, like you rightly noted. Nigeria is a peculiar country, and it will surprise you to know that up to this phase of the response, we still have a state in the country that does not believe that there is COVID-19, and there's still a good proportion of persons that do not believe that COVID-19 is real. So now, not to talk of now that we started rolling out vaccines, yes, only few persons have received these vaccines, but the low numbers we are getting is also making it more complicated. As a public health institute, our messaging has been consistent that we must continue to combine the non-pharmaceutical interventions alongside the vaccine rollout, because we're still a long way to getting and achieving a herd immunity in the country. So we keep doing that. We still utilize all our communication channels. We depend so much on the religious leaders, faith-based organization leaders, traditional leaders, and those that really have contact with the people at the community level to drive the importance of this. This has not been very easy. We still have a lot of people, not adhering to these guidelines. Recently, the Presidential Steering Committee released a revised guideline, more or less restating the regulations around COVID-19, and it has been very well publicized. We're doing our best to keep countering rumors and false information with facts and data, and also the news of what's going on in the countries around us is what we are also leveraging. We warn people that we are not yet out of a crisis, and we have to maintain what we have currently. So that is where we are in the country. We have not changed our messaging. Our messaging still remains, and our public health advisory still reads, people should continue to adhere to those NPIs. Even if you have been vaccinated, keep wearing your face mask, keep maintaining the physical distancing and so. But adherence has not been that wonderful. Thank you.
Thank you. Wilmot, I'd like, if it's okay, I'd like to go to a couple of related questions that came from the audience. One was to you, Wilmot, about the report. What does the report have to say about the role of religion, tradition, and culture, both as impediments or opportunities in concerning the strength of the COVID message? And then for Dr. Ochu, there's just a closely related question. The question goes from a member of the audience. I'm aware of leaders of certain faith-based organizations with large followerships and some political figures in Nigeria discrediting COVID-19 vaccine. How is the NCDC circumventing this obstacle? These are tough questions. So Wilmot, do you want to take the general one first?
Happily, it's a great question. Thank you very much to the person asking that question. So I'd like to reframe the question slightly. It's not about tradition or culture or religion as much as it is about points of view that would be misleading in terms of what it is individuals should do to protect their own health. So it's about misinformation, disinformation, conspiracy theories that sometimes is a product of tradition, which is a very broad category, sometimes a product of religious views and so on. The key thing is to frame it as information or messages or points of view that are contrary to what is required for one to take care of one's own health, without suggesting that it is somehow associated with a tradition or religion. So the evidence is pretty clear, and I'd like to refer you to a wonderful report published by the Wellcome Trust. I'll see whether I can pop the link into the chat in a second. And it's called Effective Ways to Increase Vaccination Rates, what the evidence tells us. And what it tells us is that you don't try and rebut misinformation or disinformation. You don't try to counter that with alternative facts. That just makes it worse. Okay, it reinforces the conspiracy often. So what's much better is to do two things. It is simply to affirm and amplify what are, broadly speaking, extant positive views on vaccination. In most countries, the majority of the population, more or less, some countries more than others, are actually quite positive to it, and parents are towards their children. So it's a minority of people are not positive. It's a minority of people who disbelieve it. So what you want to do in your messaging is amplify the positive side. The second is that you need to build attitudes towards vaccination as a community norm. It is something that communities do. And it's something, therefore, that your peers do. And the more your peers do it, the more your family does it. People, the wait and see attitude that we see, let's see what happens, is a common global thing. Human beings do this, right? So very few take the lead, but once they take the lead, others follow. And so just to say that there are two things here. The one is affirm in your messaging the positive side of vaccination by citing the number of people who have been vaccinated, and to use it in your public messaging, which means that you require a vaccine surveillance system that operates, that can generate that data. Secondly, what you want to do is affirm the fact that this is a community norm, and that the more people around you take vaccines, the more they affirm the community norm. So that would be my response to that very important question. I'm going to see whether I can pop the link into the chat.
Okay, thank you. So Dr. Ochu, and this is related. I'll just repeat the question. The questioner said that the questioner was aware of leaders of certain faith-based organizations with large followerships and then some political figures in Nigeria discrediting the COVID-19 vaccines. So how is the NCDC circumventing this obstacle? And I know this could be related to Wilmot's response as well, but please.
Yes, very great question. And I don't think it's peculiar to Nigeria. This has been a problem in many countries of the world. What we have adopted as our strategy is to engage these people more. We've identified them as key stakeholders, as trusted voices, because they have large followership and their followers tend to believe them. So we try to empower these ones with information, with trainings. So we've had organized trainings, formal trainings for religious leaders, traditional leaders, bringing them in and making them part of our intervention. So they are part of the process. That has worked. Yes, there are a few that have been adamant, but this has not deterred us. I think what has helped Nigeria also is the kind of incident management structure we have that utilizes an integrated system in public health response. So we have structures that move from national down to the community level that has supported our activities around other disease outbreaks like Lassa fever, even during the Ebola crisis. So we, and of course, polio has been very, very key in what we are doing now. The Emergency Operations Centers has been a platform for bringing in relevant stakeholders to take decisions, to be involved in the decision-making process. So we have continued to utilize this form of engagement in making sure that we turn these ones that would have been opposers of the interventions into champions for our public health interventions. And how that happens is to be transparent and to provide data and to provide valid information to them, bring them in that process of development of public health interventions in crafting our risk communication messages. So in the churches, for instance, we have a lot of the pastors and religious leaders that help us to communicate to their congregation and to enforce COVID-19 compliance to COVID-19 preventive measures. And so also with the Muslim, the mosque and all the other religious, it's just a few of them that are still at them about. The interesting thing is that information still gets to members of their congregation, and we keep trying to engage them and to bring them in. I don't think there is any magic bullets that solves the problem, apart from more intensive community engagement, engaging these ones and getting them involved in the decision-making processes. With time, they will understand that, no, this is not a hoax, there is no conspiracy here, that these are facts, and based on what is happening around the country, that also guides the decisions by these leaders. That has been our experience in Nigeria. Back to you, Robert.
Thank you. Okay, so this is the last question I have from the audience that basically offers you a chance to kind of fill in any gaps in the discussion. The question is, what are the major social factors driving vaccine hesitancy in Africa? How will these be addressed? And I'm gonna add to that social and political, in case Youssef Cherif wants to add anything on that. Has anything been missed that you would like to talk about further?
I think the social, the political reasons here are mostly related to the lack of trust by politicians in COVID itself, or lack of awareness of the danger of COVID itself. And therefore, when citizens see that their political leaders are not getting vaccinated, are not hidden at home in fear of COVID, they don't trust it neither. So that pushes more distrust among the population. I think also, at least in Tunisia, when we've seen a lot of political rallies in the last few months, organized by the main political parties, so a lot of citizens just see that and say, well, why would I worry if these guys who in theory know better are not worried? But then, so this is the political level. But then when it comes to the social and economic level, I think the answer is not very sophisticated. People are struggling economically, and they see that if they don't work and if they don't continue their normal life, they will suffer. And therefore, for them, the risk, and I've seen some of these comments in the questions, people reflecting some of these comments in the questions, people will say that, well, I didn't get COVID today, I won't get it tomorrow, but today I need to eat and I need to work, and therefore, what happens is that people simply say that, well, either it doesn't exist, COVID, or it's not that dangerous, and therefore also they refuse to get the vaccines. And usually these are the same people who do not get the flu vaccines, and so on and so on. So the anti-vaxxers, even though they don't claim it as an ideology, but they belong to that group. So by the end of the day, these political, social, and economic reasons make a lot of people hesitant towards the virus itself, but also towards the vaccine.
Thank you. Anyone else want to speak further to this question? I've got other questions. No?
I wanted to say that what drives the anti-vaxxer movement is partly a global issue, but it's the anti-vaxxer movement itself is an organized one, and it has obviously consequences in terms of people's attitudes, but it's a small minority around that. The key thing, Youssef pointed this out, the key thing here is about national political leadership on this question. So if your leaders, it's very clear from the survey results, if leaders are key in this area and they take the right stance in the highest levels of government, then that makes a huge difference. But leaders have to be trusted, and the trust levels around leaders are very uneven.
Okay, thank you. Okay, I've got another very good question. What have non-European powers, especially China, been doing here? Any comments on that? No? Yes, Youssef.
I do have a small comment here because I've been following this topic, especially China and also Russia. When you look at the vaccines distribution, at least in North Africa, the Europeans did distribute more vaccines to North Africa and did distribute more aid to the economic, to solve the economic situations that were triggered by the COVID crisis. But China distributed some vaccine jabs, Russia even less so, so Sinovac, Sinopharm, and the Sputnik. However, they were able to, again, speaking about communication, they were able to communicate that as everything. So a lot of people at least from what I can see, a lot of people do believe that China did offer more aid to Tunisia or to Morocco than the EU. But again, the key here is how they were able to communicate the way they dispersed aid, and at least it's working.
Very, very interesting. Now I have a question kind of related to the vaccine issue, and this is a question that I have that goes beyond the report on Africa, but is relevant there. In the United States, there's been a little confusion about the quality of the vaccines, and there've been some serious issues that arose with regard to the Johnson & Johnson vaccine, to the point at which that the J&J vaccine has been discussed as being representing a setback for the Biden administration with respect to its distribution of the vaccine. And this is the question I have, and perhaps Dr. Ochu can comment with regard to Nigeria. How have Africans thought about the different vaccines and the quality of them, and has that in any way affected their reluctance with regard to vaccination? I mean, there's been confusion here, and also there was discussion about the quality of the Chinese vaccine and the Russian vaccines and so forth. Has this added a further dimension and complication to
thank you, Robert.
the issues in regard to vaccination in Africa?
Yes, Robert. Yes, it's been the fact that people can access information online and get to know what is happening in other countries definitely has led to fear in the hearts of many that it's possible the speed with which these vaccines were developed could mean that there might have been compromise in quality. The good number of persons may not want to receive the vaccine because of that. And that is where also we have to do a lot of, unfortunately in the country, we've only had access to the AstraZeneca vaccine. We're actually looking for vaccine for our people. And that's the one we've been able to assess. And fortunately, on the other side, it's had a fairly good safety profile, and we've not had much issues of adverse reactions. We've also developed a system for tracking these adverse reactions. The Nigerian agency for that is the NAFDAC, Nigerian Agency for Food and Drug Administration. So we've come up with an app, electronic app, for reporting these adverse reactions. Definitely, people will be scared to take, what they think has not gone through the normal duration that it usually takes to come up with an effective and safe vaccine. But what we have is still relying on the existing scientific evidence and being transparent and honest about what we know and what we don't know. Because we don't try to deceive people to tell them we know what the impact of this would be in the next 20 or 30 years. No, we don't have that information now. But being transparent means that people are more likely to trust you, and they are more likely to look at the evidence that are available and take the decision for themselves. We have not also made it compulsory that you must be vaccinated, but we try to provide compelling evidence to make you decide to get vaccinated, because that seems to be the only key towards controlling this outbreak, this pandemic as at now. Thank you.
Okay, thank you. Okay, so just to follow up, we have another question from the audience that bears on the extent to which these scientific and expert voices and opinions are heard, and the context here is that leaders need to be trusted, and in North Central Africa, where there's little trust in politicians and the military are in control in certain countries, how do these governments overcome this mistrust? And more important is, with regard to your comments about the importance of information, is enough space allowed for the trusted scientific and expert voices to be heard? And so there's a political aspect of this that perhaps both, and a scientific aspect of this that perhaps either of you could comment on.
Okay, I guess that question is for me.
Yeah.
What helped us in the country is that we had that strong political support for COVID-19 interventions in the country, with a strategic high political leadership at the level of the Presidential Steering Committee, headed by the Office of the President himself, the Secretary of the President himself. So, and that committee, initially it was the Presidential Task Force, PTF, depended on scientific evidence for their decision. So there has been a lot of support for science in driving our response. At the Nigeria Center for Disease Control, we have an epidemic intelligence unit that looks at data and what is coming up, and is able to provide support. Also at the national level, we were able to convene a coalition of scientists with policymakers and those from research institutes. We call it the Nigeria COVID-19 Research Coalition. And this coalition was formed very early in the outbreak, April last year specifically. So, and this, we have over 50 institutions that are research-based, collaborating with policymakers, high-level policymakers, as well as the people from the industry. We have the Manufacturers Association of Nigeria's members of this coalition, and the private sector. So bringing together scientists to have a platform where they interact with policymakers means that evidence generated through research can readily be translated into policy and practice. And I must say that for this pandemic, we've seen a lot of evidence-driven policies and practice. Most of our guidelines have been based on evidence. And then there's also a new trend of events that I think other African countries should also emulate, where NAFDAC has brought together herbalists, indigenous medicine practitioners to work in collaboration with academic scientists to test their products and to see if we can come up with indigenous solutions. So a lot of attention has been given to science. For that, I will say that we've done very well in that regard, except for the fact that funding is still not optimal for science, research, and development in the country. It's still an area that is heavily underfunded. And that is where we are hoping that there will be an improvement. Thank you.
Thank you. Thank you. Okay, I've got two more questions here, unless Youssef wanted to comment any further about the space. Okay, so here now, I was intrigued by this when you mentioned it in your discussion, Dr. Ochu, when you talked about social media. So we have a question from one of the audience members who says, I'm also wondering in the case of Nigeria, where there's been federal restrictions on some social media micro-blocking sites, is the NCDC able to address the infodemic and convey messages en masse to Nigeria's dynamic, youthful population that are attached to social media?
I think I will not delve into that political question, and I think there is a better, maybe the politicians can address that. But for us as a body, we have tried to make maximum use of what is available to us. Fortunately, we've been able to have a very robust communication. We've had very robust communication channels before these restrictions. So what we're doing is strengthening the existing ones and using them to pass the same information, and also exploring other non-traditional means that will be effective in getting the information to people. Thank you. Okay,
and then one more question here that hasn't come up recently, but I think is an important one. There's the issue of what problem that migration can cause related to this spreading the pandemic further. And so the question asks, for migrants who are entering or leaving the countries, is there any thought about people at some point having to prove whether or not they've been vaccinated or not, and is that a problem that's foreseeable in the future? I've reframed that a little bit.
Okay, that addressed to me, so I can
yes
answer that, and then Youssef can also
yes.
Something. So yes, migration has been a key factor for cross-country transmission of the virus. That is why most of the strategies have also focused on strengthening detection at that level and preventing importation of the virus into the country. In Nigeria, for instance, we still insist on presenting a negative result before you are admitted into the country. And even with that, you are expected, the person that is coming in, the migrant, is expected to self-isolate for 7 days and then get tested after, on the 7th day before he's allowed to get integrated into the society. So these are all key measures to lower the risk of importing the virus. Yes, we've not started using vaccination now because we understand that many nations still do not have access to vaccine. But where vaccine becomes accessible, then it becomes morally justifiable to ask someone to show vaccination record before you come in. But when you've not given opportunity to that person to get vaccinated, and many countries now, like Nigeria, we still do not have, we've not covered up to 1% of our population. We have just 0.02%. Well, thankfully, there have been a lot of collective efforts to see that, especially I must commend the efforts of Africa CDC, WHO, and all the other organizations that are trying to make vaccine available and accessible to low to middle income countries. So that is what we are hoping for. When we get to a particular stage, I believe that it could become a criterion for admitting someone into the country, but not to say anything more than that. So Youssef, you can add to that if you have.
So the one point I would like to add about is related to, in relation to migrants, is that I think in places like Tunisia or Morocco, where there are tens of thousands of migrants or informal dwellers who do not have all the required documents, or who have their documents as asylum seekers, etc. There are no specific campaigns that were taken to vaccinate them. And even though in theory they can be vaccinated, but so far the mechanisms to get the vaccines are not at reach. They don't have the necessary documents to get registered. And so therefore, that on the long term, there needs to be a strategy by these governments to vaccinate these migrants. But of course, the main argument that the different authorities will use is that we're not even able to vaccinate our own population, so we cannot open up now to non-citizens. But also one point I wanted to come back to, I read in the questions, the question about whether people should be convinced to get vaccinated or whether it should be enforced. And so here, I think we're back to that story of the chicken and the egg related to democracy versus authoritarianism. So yes, the easy answer is that there needs to be more enforcement of the push towards vaccination. And that may help getting more and more people vaccinated. But that's the easy answer. Now, the more complicated answer is that usually that's what authoritarian regimes do, not for the good, but rather to be even more authoritarian. So we've seen that in some authoritarian countries that are actually using more and more restrictions in the name of fighting COVID, in the name of pushing people to get vaccinated. I think in one Asian country recently, the president said that you get vaccinated or you go to jail, and these kind of arguments that actually will only strengthen authoritarian regimes and not necessarily get more people vaccinated. I think the main, the key here is not to be more violent towards the population, but rather to open to civil society, to open more space to civil society, to disseminate more information about COVID and about the vaccination, and for the states actually to use civil society for this endeavor, and that will be much more useful than enforcing and using the stick to get people vaccinated.
Yes, yeah, it was the case of the Philippines that there was an announcement about vaccine requirement, very heavy-handed. Okay, one last question. We've talked about government action here. To what extent is local government poised to play a greater role or lesser role in dealing with these issues? Is there an important distinction to be made there? Now, obviously, in the United States, it's come into play because of the different states and localities. But we've talked about government in Africa. But should a distinction be made between the local and national governments?
Okay, maybe I can start off.
Yes, please.
Yes, I can start off with that. In Nigeria, we have 3 levels of healthcare. We have the tertiary, the secondary, and then the primary healthcare. I think what COVID-19 pandemic has made more obvious to all, the fact that we need to strengthen healthcare at the primary level, because that is where the closest care to the people, and that is where case identification is done. That is where case detection, so to say, starts. In the country, we have an integrated disease surveillance and response system that is driven from primary healthcare level up to the state and then to the national government. For us to achieve or attain universal health coverage in the country, there has to be deliberate effort to strengthen primary healthcare level. That is a level of care that also enjoys more trust, because you relate more to the contextual issues of the environment where they are. And prior to this time, there has been little emphasis on PHCs, primary health care centers. So it is important that the government of every nation will utilize this opportunity. There's been a lot of inflow of resources. And for us as a country, we've been able to use that to build our public health system in such a way that we now have public health laboratories in all the states of the Federation. We've also prioritized disease surveillance at the primary health care level. So we have a data collecting tool we call SOMAS that we have deployed to all the 774 local governments of the country, because we understand that detection must happen, case identification must happen at that level. So we are making conscious efforts to strengthen subnational structures and get them to be more responsible in driving the response than the national level. It will take some time, but we have noted a lot of gains in that. And we are hoping that all the other sectors, all the other key players and stakeholders will also place emphasis on these subnational institutions. Thank you.
Thank you. Okay, well, unless Youssef has anything to add here, no. Well, we're at the end of our allotted time. Dr. James had to leave a little bit early, but on behalf of Wilmot James and myself and our partnering organizations, I want to thank the audience for joining us today, and I especially want to thank our panelists, Youssef Cherif and Dr. Ochu. Thank you very much. Bye-bye.
Thank you for wonderful moderation, Robert.
Thank you. Thank you.
Thank you.
Thank you.
Bye-bye, everyone.
Bye-bye. Bye.
Bye, sir.
Bye.
Bye.